The electrophysiologic potentials are recorded using surface as well as invasive electrodes. 3 electrodes are required to record from a site. They are called active, reference, and ground. The reference electrode often conveys the impression that it does not record any electrical activity. That is quite wrong. Hence, we refer to the electrodes as E1 for active, E2 for reference, and ground. Some use terminologies like G1 and G2. While those terms reflected the connections to different grids of a vacuum tube used to build an amplifier, that technology became obsolete decades ago. Hence, we suggest that terms G1 and G2 should not be used. The electrodes are often recognized by the color of the lead connected to it. The active or E1 electrode has a black lead that connects to the black input on the amplifier. The reference or E2 electrode has a red lead and red input on the amplifier. Finally, the ground electrode has a green lead and a green input. This is a convention that most instrument manufacturers follow in the design of their systems. The motor nerve conduction studies are performed using surface disc electrodes. Here is an example of reusable metal disc electrodes. They have a diameter of 10 mm. After applying some conductive gel, they are secured on the skin surface using a sticky tape. Here is an example of disposable disc electrodes. They have a diameter of about 18 mm. They have an adhesive and conductive gel on them. They can be moved from one side to another quite easily. The difference in their shape and size can affect the voltage they record. Larger electrode will measure a slightly lower voltage, but it is more reproducible. In our experience, the amplitude difference between these recording electrodes is not significant. For pediatric studies, these electrodes may be quite large. Hence, some laboratories use pediatric EEG cup electrodes for pediatric conduction studies. They have a diameter of 6 mm. The ring electrodes are used in sensory nerve conduction studies. Here is an example of reusable electrodes. Upon placing them over fingers or toes, they are tightened using the rubber ring. Electrolytic gel is applied to improve the contact between the skin surface and the electrodes. Here is an example of disposable ring electrodes. These electrodes also have adhesive and conductive gel. In this example, external leads with alligator clips are used to connect the electrodes to the amplifier. The distance between the ring electrodes affects the amplitude of the sensory nerve action potential. In this study, we increase the distance from 7 mm to 47 mm. The amplitude values are tabulated. When the distance was 3 centimeters or more, the amplitude of the potential increased only slightly with distance. Shorter distance resulted in much lower amplitude. Hence, the operator must make sure that the distance between the ring electrodes is standardized. Most laboratories use 3 to 4 centimeter distance. A bar electrode contains 2 recording discs mounted in a plastic block. The electrodes are available with a distance of 3 to 4 centimeters between the discs. The fixed distance between E1 and E2 is a benefit for recording the sensory nerve action potential. After applying electrolytic gel for good contact, the electrode is secured over the recording site using a sticky tape. This arrangement is also used when the bar electrode is used as a stimulator in repetitive nerve conduction studies. Many laboratories also use the bar electrode for stimulating at sites that are difficult to access. For example, the axilla. The ground electrode is used to reduce noise and artifacts. Here are examples of a disposable and reusable ground electrode. A ground with large surface area is more effective than a smaller recording surface. In a nerve conduction study, the ground is placed between the stimulating and recording sites to reduce the stimulus artifact. In needle EMG, placing the ground electrode close to the needle insertion site is more effective to reduce the background noise and interference. The routine needle EMG examination is performed using intramuscular concentric or monopolar electrodes. The concentric needle consists of a 150 micron diameter wire inserted in a hollow metal cylinder called the cannula. The tip of this assembly is ground at 15 degrees angle to expose an elliptical recording surface called the core. The surface area of the core of a standard concentric needle is roughly 0.07 square millimeters. The core is the active recording surface, while the cannula is used as the reference electrode. The monopolar needle consists of a solid metal wire that is coated with Teflon. The tip of the needle is ground to expose a cone-shaped recording surface with an area of roughly 0.2 square millimeters. This is the active recording surface. A separate surface electrode is used as the reference electrode. The recording surface of the concentric and monopolar needle are compared. Due to differences in the geometry and area of the recording surface, we do expect some differences in the signals recorded by these needles. Quantitative analysis of motor-unit potentials and interference pattern shows that monopolar needle gives slightly higher amplitude motor-unit potentials. The incidence of polyphasic motor-unit potentials is also slightly higher with monopolar needle EMG. In our experience, the motor-unit potential duration is similar for concentric and monopolar needles. However, some investigators have reported slightly longer duration in monopolar needle EMG. The EMG examination requires insertion of a needle in the muscle. It is painful. If the needle is thicker, it will be even more painful. Hence, a thin needle will be preferable. Indeed, the so-called facial or pediatric concentric needle is much thinner than the standard concentric needle. The facial needle from one manufacturer uses 30 gauge cannula compared to 26 gauge cannula for the standard needle. Note that a higher gauge implies a thinner cannula. This can be confusing. It would be quite tempting to use the facial concentric needle for all needle EMG studies. However, this is not possible. A thin needle can bend easily with forceful movements. Hence, it must have a short length. Typically, the facial or pediatric needles are only 25 mm long. It implies that they cannot reach deeper muscles such as the paraspinals. Secondly, the central wire of the facial needle is also thinner. Hence, the core of this needle has a recording surface of only 0.02 to 0.03 square millimeters compared to 0.07 square millimeter of the standard concentric needle. The smaller recording surface gives slightly higher amplitude potentials compared to the standard concentric needle. Besides the study of the superficial muscles, or in children, the facial needle is also used for jitter analysis instead of the reusable single fiber EMG electrode.